Hello friends, I am Dr. Agam Vora, chest physician from Mumbai, and we are going to be talking about ARDS today. A new molecule called Aviptadil in the management of ARDS. Science has progressed by leaps and bounds, and we are in far better position understanding lung behavior than ever before in various clinical situations, including ARDS. And we've made tremendous progress in our understanding of ARDS in the last 3 decades. I remember as a student, ARDS would have almost 100% mortality. Ventilator would be used only to buy time. But we've come a long way now with so many new strategies like low tidal volume, permissive hypercapnia, lung recruitment, prone ventilation, inverse ratio, sedation and paralyzing agents, fluid management, the better use of steroids, and we've been able to make some difference in outcome of this ARDS patient. But still there are times when you feel helpless and your mind looks for possible solution. Today I'm going to present to you one such molecule called Vasoactive Intestinal Peptide for your consideration in ARDS. I had the opportunity to using it in some of the COVID-19 ARDS. You may not have heard about this molecule as it belongs to a group called orphan drugs. Well, orphan drug would mean that a drug which is intended to treat condition which affects fewer patients, say a relatively rarer condition, say about 200,000 patients in a year, that would be a rare disease and which is unlikely to make profit in 7 years following its approval. It's called orphan drug, and this particular molecule was used in a variety of other disorders which are orphan. Over time, when we were in tough situation where we were losing patients like crazy during ARDS, during COVID, the second wave, we started looking at options, and there came this particular molecule, and we started using it with some success. And here I'm going to present to you the data that we had during our COVID experience. Allow me to share my slides. Yes. At the outset, I must express my sincere thanks to my teacher, Professor Director Dr. K.C. Mohanty. My teacher, Dr. A.C. Shah, under whose able guidance, we had a 6-bedded dedicated IRCU, a respiratory care unit, and all my graduation and post-graduation, I had the chance to work in that ICU, and then we had 8-bedded step-down ICU or the recovery ICU before the patient would be shifted to wards. All my patients who gave me chance to learn respiratory medicine. Education partners for today's program, and that is Team Zuventus. My association with them is almost 2 decades old, and I've had the pleasure of, they have given us one after the other innovative products, and I've had the pleasure of working very closely with their medical team under the leadership of Dr. Bhupesh Diwan. Of course, all of you for sparing your valuable time to be with us, because it's only your presence that probably encourages us to do more and more programming. And acute lung injury and ARDS, let's try to understand. Acute lung injury and ARDS is a more severe form. We used to look at ALI and ARDS as 2 different things. Now we are not looking at ALI as term, and we look at ARDS as mild, moderate, and severe ARDS, but both are characterized by hypoxia, which is resistant to oxygen therapy. That means in spite of your increasing oxygen support, there is no corresponding increase in patient's arterial oxygenation, and that is resistant hypoxia. Most of this patient would require ventilatory support because their respiratory hypoxic failure is severe and it is prolonged. The acute phase is characterized by exudative alveolar flooding due to pulmonary capillary leak and by extensive alveolar collapse due to loss of normal surfactant activity. And you have strategies, the intervention which are directed at modulating this inflammatory and other pathways of lung injury. You need to optimize the alveolar fluid clearance or restore the surfactant function, which may have some positive outcome, but at present, no specific pharmacological therapy has shown to make difference. Huge problem. 3 million patients annually, and if you make rough calculation, by the time we finish this slide, there would be a few patients who developed ARDS. According to various studies, about 10% of ICU admissions are ARDS. 24% of the patients who are on mechanical ventilation may have underlying ARDS. Huge mortality, 40 to 60%, depending on the severity, the time that lapsed, delay in diagnosis, etc. And a good centers document about 30% incidence with as high as 40% mortality, and an average ICU will have mortality rate in the tune of 80 to 100%. During SARS-CoV-2, we had the prevalence of ARDS during the tough wave, the second wave that we see somewhere around 25 to 60%, depending on the centers. Earlier, we were looking at ALI and ARDS, but now we are looking at ARDS, which is mild, moderate, and severe. So whenever you have any presentation which happens within 1 week of a clinical insult, which is known to result into ARDS, and trust me, anything and everything can result into ARDS. When you don't have any explainable cause for this respiratory failure, and which is not a cardiac edema in origin or the pulmonary edema in origin, you're looking at ARDS. Whenever you have bilateral opacities which are not explained by any other condition, you're talking about ARDS. And then there is hypoxia. Your PaO2 by FiO2 ratio, depending on the value, you would divide them into mild, moderate, or severe. So if you have less than 300, it is mild, less than 200, it is moderate, and when it is less than 100, it is severe. So PaO2 by FiO2 ratio, you need to draw blood gases, calculate PaO2, whichever FiO2 you are giving, take the ratio, and when your PEEP requirement is more than 5, or your CPAP requirement is more than 5, you're talking about refractory hypoxia, and that is the definition, or that puts this patient into mild, moderate, or severe ARDS. So you need to have injury which happens within 1 week. You have to have no other explanation for those bilateral pulmonary infiltrate. You have to be sure that it is not cardiac in origin, and there is severe hypoxia, makes you categorize them into mild, moderate, and severe, depending on the PaO2 or FiO2 ratio. And anything and everything. Look at this complex diagram. You can have vasculitis resulting into it. You can have gunshot injuries resulting into it. You have drowning and near drowning resulting into it. You may have trauma resulting into it. You may have shock, pneumonias, aspiration pneumonias, and not to forget COVID-19. I have at least 2 patients who are immunocompromised and are on ventilator at this stage. And this is what is the definition of a mild, moderate, and severe ARDS based on the PaO2 by FiO2 ratio. As I said, less than 100, you have severe. 100 to 200 is moderate, and 200 to 300 would be somewhere around mild. And look at the mortality. Your mortality rises from around 37 to 45% when ARDS progresses from mild to severe. Common things that you see in your practice are generally aspiration pneumonias and pneumonias, community-acquired pneumonia, or pneumonia which are happening in elderly, or pneumonia in immunocompromised state. You may have less common causes such as inhalation injury, pulmonary contusions, embolism, near drowning, etc. You may have even pancreatitis, drug overdosages, burns, and head injuries resulting into ARDS. In fact, last week, my father got admitted with ARDS. He had a big patch of pneumonia, presented with 3 days of fever with chills, and had to be hospitalized. On investigation, we found out there was a patch of pneumonia. In no time, he deteriorated. He went into sepsis with multi-organ failure, developed acute renal failure, had to be dialyzed 3 times. So this is the presentation, and this fast could be presentation. What happens? The epithelial cell injury, which is not only important in development but also in the repair, because these are the cells which would decide the outcome of disease as well. Degree of epithelial injury can predict the outcome. Loss of epithelial integrity and injury to these type 1 alveolar cells, which are mainly responsible for integrity and surfactant function, disrupt the normal fluid transport, and hence the impairing removal of fluid from the alveolar space. It reduces production of surfactant, and which contributes to clinical course of worsening of collapse and the gas exchange. You have 2 phases. The early phase, which will be exudative phase, where there will be a lot of inflammatory fluid in the alveoli. They will be filled with it. There will be diffuse damage. And then comes the next phase, which is about 3 to 7 days. The patient is not badly infected. This phase would begin 3 to 7 days, where there is lung repair and type 2 pneumocytes, hyperplasia, and the proliferation of fibroblasts occurs. Unluckily, there is no specific drug, and there cannot be any specific drug because there is varied etiology right from infection to inflammation to think of anything which can result into ARDS. And I believe the therapies will be, probably targeted to two things. One is the insult. You have infection, obviously you have to look at antibiotics. You have viral infections, antivirals, fungal infections, antifungal. You have underlying pancreatitis or underlying burns. Your treatment will have to be directed towards that. And second thing is your immunity. And then there are a lot of immunomodulators or various things that we've realized would probably strengthen patient's immune reactions. And any disease is actually a human host reaction to that particular injury. And that's what ARDS is all about. Trust me, there is no approved pharmacological treatment or accepted pharmacological treatment for ARDS which reduces mortality in long term or short term. It is obviously clear that we need newer drugs with different mechanisms which may change the outcome of ARDS. And here I present one molecule, which is Aviptadil. Look at what happened. Oh, there's huge damage which is going on. This is the alveolar type 1 cells here. You can see that this is alveolar type 2 cells here. And with injury, there is epithelial cell death going on. There is activated platelet. There is platelet aggregation going on. There is capillary damage. There is endothelial damage. There is disruption of the tight junctions. Fibroblasts come in picture. There is so much of edema that the alveoli filled with fluid, and then there is no gas exchange happening. Very interestingly came across that there are various phenotypes. So there are various components of damage at the alveolar level. There are 4 types. One is a predominant epithelial injury. So you can see that this is a predominant epithelial injury. There may be a extracellular matrix dominant injury. There could be injury which is endothelial dominant injury. You can see that. And there could be a injury where there is a coagulopathy dominant injury. And I'm sure everybody here would now try to recollect, we had during COVID a lot of injuries where it was happy hypoxia kind, which was mainly a endothelial or mainly a coagul or mainly a thrombus induced injury. And what you see commonly in pneumonia is your epithelial dominant injury. And based on this, you could look at various therapeutic options. So we have used most of these things you've used dexamethasones, you've used high dose vitamin C, but then there are so many newer molecules available. We have also used streptokinase, we've also used nebulized heparin, and then there are various recombinant ACE2 and citrulline therapies available. There is alpha-1 antitrypsin therapies available. There is imitinib, bevacizumab is available, and then there are various treatments which target various things. In fact, RAGE inhibitors and adenosine A2A receptor agonists are also being tried, which would work on the sodium and potassium channels. With those background, let me tell you about this Aviptadil, a new molecule which got we got chance to use this particular molecule during this tough times, COVID times. So what is this VIP? It's a vasoactive intestinal polypeptide. It belongs to secretin, a glucagon hormone superfamily. Consists of 28 amino acids. And it is widely distributed. Trust me, it is widely distributed among nervous system, digestive system, cardiovascular system, respiratory, and reproductive system. There are 2 receptors for this vasoactive intestinal peptides, and it's called VPAC1 and VPAC2. It is expressed mainly in the neurons of central and peripheral nervous system, but it is mainly localized, highly localized in lung, with 70% of it is being in lungs. Also, it is in mesentery, submucosal neurons, and the terminals of GI tract. It is released by numerous stimuli by both cholinergic and non-cholinergic nerves. And it has got its expression, and it is released by endocrine organs like heart, thyroid, kidney, GI tract, immune organs like spleen, thymus, bone marrow, etc., and immune cells like activated T cells, macrophages, B cells, as well as mast cells. Hence, it is found throughout the body, and in healthy volunteers, the concentration could range between 14 to 76 picograms per ml. When I think about it, actions, when I read about it, action, it really interests me. It has got anti-inflammatory action. It blocks apoptosis, that is caspase 3 activation. It inhibits inflammatory cytokines like IL-6. It reverses CD4 to CD8 ratio. It reduces pulmonary inflammation by reducing production of pro-inflammatory cytokines, inhibits activation and synthesis of NF-κB. It increases pulmonary surfactant production. It reduces ischemia and perfusion-related injury and reduces cell death by inhibiting activation of perforins and granzyme B. It binds to receptors on alveolar type 2 cells in the lung. I'm sure everybody here is aware that this is the receptor where SARS-CoV-2 virus also bind through their ACE2 receptors. So this type 2 cells has got multiple receptors. ACE2 receptor is one such receptor to which SARS-CoV-2 virus binds, and this is the receptor where even Aviptadil binds. So SARS-CoV-2 virus would attack these cells, and it results into death of these cells, which produces surfactant, which results in defect in oxygenation with hypoxia. And Aviptadil results in rapid clinical recovery with this infection, as it blocking of the cytokine, prevents apoptosis, and upregulation of the production of surfactant. So look at this cartoon where we are talking about pulmonary alveolar type 2 cells, which produces surfactant. These cells will have high concentration of A2 receptors. Your SARS-CoV virus could come on the receptor and would bring about all these inflammatory changes it does, and BIP will be highly concentrated in lungs, bind specifically to these receptors on type 2 cells, and will upregulate the surfactant production and would probably minimize the damage which otherwise happens with COVID-19 surfactant-related injury. Let me show you a few studies, and this is one pilot studies which was done with this particular syndrome in a small number of patients, eight patients, and 7 out of 8 patients demonstrated successful course, and 6 patients demonstrated successful 30-day survival, and it was concluded that it shows promise in the treatment of other infectious conditions that damages pulmonary epithelium, including COVID-19. This study was looking at increased recovery and survival in patients with COVID-19 related respiratory failure. Almost 200 patients confirmed COVID-19, and 12 hours infusion of Aviptadil over placebo over 3 days resulted in, it was concluded that patients who were on study drug, that is Aviptadil, are more likely to be alive and free from respiratory failure at the end of 2 months, and that those average 10-day reduction in the length of their hospitalization. It was concluded that treatment demonstrated multidimensional efficacy in improving likelihood of recovery from respiratory failure and 60-day survival, and the reduction in number of days in hospital due to respiratory failure, which was caused by COVID-19. There was another paper which speaks about a 54-year-old man with double lung transplantation who was treated with dexamethasone tocilizumab without much of improvement due to the COVID-19 infection, which resulted into respiratory failure and mild ARDS. This patient received Aviptadil total of 3 doses, and there was significant improvement in oxygenation, radiological finding, and this patient was transferred out of ICU within 24 hours of receiving 3 dosages. And you can see that before and then there is 24 hours infusion, it showed significant improvement. So you may have a super responder. Of course, I'm not saying that every patient would do well, but then as you would agree, there are some patients who are super responder, and this patient belong to that super responder category. Trust me, there are numerous trials going on. There are numerous trials going on with COVID-19 and respiratory failure. I was looking at various proposed mechanisms, and it preserves pulmonary tissue by its caspase-3 activated lung injury reduction. It inhibits alveolar epithelial apoptosis by restoring the barrier function. It promotes the synthesis of pulmonary surfactant by upregulating surfactant. It inhibits various cytokines and reduces pulmonary inflammation. It has got multiple action. It has got action in circulatory system, central nervous system, endocrine system, digestive system. But what we've understood more is about their immune function, where it has got macrophage deactivating factor, anti-inflammatory action, defense mechanism activation, and it has got its action on respiratory system. I was excited to learn that this particular drug is also tried. There are various trials going on where it is tried for idiopathic pulmonary hypertension. There are ongoing trials with 20 patients with pulmonary sarcoidosis. Almost 20 patients of idiopathic pulmonary fibrosis are on this treatment. And what is exciting is there are some subjects who are put on, even resistant asthma patients who are put on this therapy. What is interesting is about the dosages. It is IV infusion that we need to use it for 3 days, 3 consecutive days, and it is given as 0.166 microgram per kg per hour. And the dose is beautifully designed in such a way that you give 1 vial of Aviptadil injection on day 1, 2 vials on day 2, and 3 vials you give it on day 3 over 12 hours. So that is 14 hours infusion at the dose on 3 successive days. So you have 60 to 90 kg. Or more than 90 kg, you would give 10 hours of infusion, 12 hours of infusion, 14 hours of infusion, which is very standard way of using this in ICU. Luckily, there are no major drug-to-drug side effects. Of course, it is not studied in pediatric population. Of course, it is not studied in pregnancy, and we don't have very vast experience of using it, but whatever available literature, whatever available pharmacology that is given to us makes us believe that it should be fairly safe drug with hardly any contraindication, with hardly any undesirable effects, and at least literature does not talk about any overdose issues. Little recap that it is decreasing inflammatory cytokine, prevents cell death. It upregulates production of surfactant and protects type 2 cell, inhibits IL-6 and tumor necrosis factor alpha. There is rapid recovery from critical COVID-19 related respiratory failure and ARDSs. It has got fast track designation and fairly safe drug, not much of toxicity. And trust me, it is really reasonably priced. Currently, it is recommended for acute respiratory distress syndrome. With these words, I thank you for your patient hearing, and if there are any interactions, if there are any questions, if there are any difference of views, I would love to address that. Thank you very much.